चलो ठीक है, मैं बोला आया। Good evening, everyone. Myself Ashish Kureta, on behalf of Eternal Hospital and Dr. J.S. Makkar and Dr. Kush Bhagat, I request all the dignitaries to please be settled so that we can.
Dr. Deependar Bhatnagar sir, Dr. GL Sharma sir, Dr. R.D. Pandey sir, Dr. Pushpendra Garg sir, Dr. BM sir, and Dr. Nikhil Choudhary. I just got a message from Nikhil sir that he won't be able to come in the first session. And Dr. C.B. Bina sir also. Connect me. C.B. Bina sir, please come.
Good evening, everyone. I am happy to see Gokru sir, our teacher, sitting in front. आप ऊपर ही आ जाएं सर प्लीज. आइए सर प्लीज आइए. नहीं यहीं बैठो, यहीं बैठो. So, very warm welcome on behalf of Eternal and Department of Cardiology. We all are here today and we are at service 24 hours in Jaipur and also in other cities. So we'll start today's CME by overview of atrial fibrillation. The target of this talk is just to remind, just to consolidate our existing knowledge about atrial fibrillation. Then over and above that, we can discuss the newer therapy which will take on in the later talk. So I'll start from very basic. So what is definition of atrial fibrillation? So atrial fibrillation is a supraventricular tachyarrhythmia with uncoordinated atrial electrical activation, consequently ineffective atrial contraction. So this second thing, ineffective atrial contraction, we sometimes forget in our mind and we just keep the electrical thing in our mind when we think of AF. But actually we should imagine atria as a standstill chamber when AF is going on, because that's what makes the pathophysiology so important. So the ECG feature is also part of definition of atrial fibrillation. Then there are few other terminologies which are relatively new, like clinical and subclinical atrial fibrillation. So this has nothing to do with symptomatic or asymptomatic AF to begin with. The clinical AF means that symptomatic or asymptomatic AF that is documented by surface ECG. Minimum duration of an ECG tracing of AF required to establish the diagnosis of clinical AF is 30 seconds. Either a single lead of 30 seconds or a full 12 lead ECG documenting AF. That is called clinical AF. Now why, please be silent, इधर audio visual आवाज नहीं करिए please. Why this term clinical atrial fibrillation has been coined? Because as we do more and more monitoring, as we see more and more implantable devices, we see more atrial fibrillation. That is subclinical atrial. And it has to be confirmed by clinical atrial fibrillation, documentation of clinical atrial fibrillation to further prescribe the therapy. So at least 30 seconds of a long lead or a full 12 lead ECG. Now, what is subclinical atrial fibrillation and what is AHRE? AHRE is a relatively new term, atrial high rate episode. So nowadays we all implant pacemakers, and most of the pacemakers, they can record AHRE, and they report it as AHRE, events of episodes of AHRE, atrial high rate electrical activity. So this AHRE events fulfilling programmed or specified criteria. For example, the pacemaker is set to record AHRE generally over 175 of rate when they also go to mode switch, and at least 5 minutes of duration of that episode to rule out any non-sustained episodes. But there can be exception. There are electrograms inside the pacemaker. If we go to the electrograms, we can see the electrograms, but sometimes we find that these are the artifacts. So any AHRE recorded should not be directly taken as evidence of atrial fibrillation, and clinical AF has to be documented either by a very clear electrogram or a surface ECG or any other method like loop recorder or implantable recorder. Subclinical AF includes AHRE which are confirmed by clinical AF, confirmed by tracings or ECG recorded rhythm, that is subclinical. So we go for classification. Generally it is classified as first diagnosed AF, like first episode. So this is considered a different territory because the treatment is different. We'll discuss later on. Paroxysmal AF is self-terminating in most cases within 48 hours, but an episode lasting up to 7 days is considered as paroxysmal AF. AF episodes that are cardioverted within 7 days are also considered as paroxysmal. So this is important. Persistent AF, AF that lasts longer than 7 days, including episodes that are terminated by cardioversion. Either so more than 7, after 7 days cardioverted, persistent AF. Before 7 days has to be cardioverted, then it is paroxysmal AF. Long-standing persistent AF and permanent AF, they are interesting terminologies. Long-standing persistent AF is probably the one of the commonest type of AF we find clinically, because we call it permanent AF when we have decided that we won't cardiovert it, we won't give amiodarone, flecainide, any rhythm control drug, and now we are shifted only to rate control. That is permanent AF. Long-standing persistent AF is continuous AF lasting more than 1 year, but still we are adopting a rhythm control strategy. If we have thought some AF as permanent AF, but again we are adopting a rhythm strategy or we are trying to cardiovert it, it becomes a long-standing persistent AF. So this is the difference in definition is because of the treatment strategy, not due to the clinical presentation or duration. Valvular and non-valvular AF, we know very well. Non-valvular AF is called only when there is significant mitral stenosis or a mechanical prosthetic valve is there. Rest of them are a bystander AF, non-valvular AF. Lone AF is terminology not used these days, but these are idiopathic AF in young patients. Chronic AF should not be used, this terminology. This is a very loose term. Either it is long-standing persistent AF or a permanent AF. When should we screen for atrial fibrillation and why should we screen for atrial fibrillation? We screen for sudden cardiac arrest. Nowadays we have started, we didn't do that for decades, but now we try to see whether there are PVCs or NSVT on Holter or any other recording technology when we are thinking of an ICD or thinking of a sudden cardiac death risk. But we are not screening for AF. So we can still screen high risk patients who are diabetic, hypertensive, high risk of stroke. There we can screen for atrial fibrillation. There is little bit evidence that it reduces the mortality. And opportunistic screening means patient has been hospitalized due to other things or he has come to clinic for some other reason. And then if you think he is high risk, can be instrument also, graphs, pulse oximetry. Gadgets like Apple Watch is very sensitive for them. Then the various event recorders, mobile-based, app-based event recorders. There are loop recorders, patches, pocket ECG for 7 days, 15 days, and of course then implantable cardiac monitors, which have been, now come in guidelines for screening of atrial fibrillation. Probably Kush will take this into account. So when we talk about burden, AF burden, so burden of AF is something different and AF burden is something different. Burden of AF is like associated comorbidity, stroke, and heart failure and so on. But AF burden is duration of patient, duration lived with atrial fibrillation. That is the AF burden. Nowadays, it can be calculated, though Holter is not a good thing to see, but 1 week recorder can, give us the indication of AF burden, and it is actually the unit of AF burden is hours per week. So a 1 week recorder can give us some idea of AF burden, but most useful thing for AF burden is an implantable cardiac monitor, that revealing kind of thing, or it can be a pacemaker or ICD, which is implanted with an atrial lead. They are very good things for to calculate the, though it may or underestimate or overestimate, but right now we have these type of instruments to collect the AF burden. Now AF burden is not directly correlated with the mortality, stroke, or all these things, but there are few studies. Like one interesting aspect is that if we look at properly anticoagulated patients of paroxysmal and persistent AF, paroxysmal AF patient will have less number of strokes than persistent AF. But that's not known without anticoagulation. But as far as I believe is that the AF burden should not be taken into account when we are thinking of anticoagulation. Anticoagulation has to be given irrespective of paroxysmal, persistent, low burden, high burden atrial fibrillation. But our therapy, yes, if burden is high, patient is more chances to go to heart failure, definitely. And progression to permanent AF is more common with high burden. Then our strategy should be to give strong antiarrhythmic drugs or do ablation or whatever needed to reduce the burden. And there was a study where it was seen that if burden was beyond a certain limit, there was high mortality, particularly in females. So definitely now the concept is coming that AF burden has also to do with mortality in the heart failure and progression to permanent AF, but symptoms or no symptoms or mortality because of stroke is not directly correlated. So we should not take AF burden into account as according to the existing knowledge when we are thinking of NOACs. Pathophysiology of AF is very interesting and has to be taken into account because today we are going to discuss the ablation. So if we know what is the pathophysiology, it is easy to understand the ablation part. So any arrhythmia is product of trigger and substrate, and in case of atrial fibrillation, trigger is either a pulmonary vein ectopic or other sources like superior vena cava, inferior vena cava, coronary sinus, ligament of Marshall, LA appendage. There are many places from where ectopics can come. Or atrial tachycardia or atrial flutter can also act as a trigger, and we see these patients very commonly where one ECG is showing flutter, other is showing atrial fibrillation, one is showing PSVT, other is showing AF. Likelihood is that patient is degenerating to AF after SVT, and if we take care of SVT, AF is taken care of. So these are the triggers. And substrate, actually atria is such a complex structure that it doesn't need a disease to produce a substrate. Like in right atria, crista terminalis, superior crista terminalis, inferior crista terminalis, appendage, tricuspid annulus, muscles. There are so many things. Similarly, in pulmonary vein itself is a very complex structure. So they provide anatomical substrate. That's why paroxysmal AF is so common even in normal hearts. Second thing is that the conduction system is of atria is probably still under evolution, not like ventricular depolarization. The ventricular depolarization happens together in RV and LV through Purkinje fibers. There are no such good fibers in atria, so it is depolarized cell by cell. So once there is atrial arrhythmia and there is little bit dilatation of the atria, then electrical heterogeneity increases and it perpetuates further the AF. So scar and fibrosis further provide the substrate and electrical heterogeneity. So we need to take care of the trigger and substrate both in cases of persistent atrial fibrillation, and triggers only probably in case of atrial fibrillation. I won't take this slide. This just shows the pathophysiological mechanisms where the atrial remodeling, RAS activation, inflammatory markers, and all other things are involved in maintenance and perpetuation of atrial fibrillation. But the most useful theory which came in late 90s was that the pulmonary vein gives rise to ectopics, and this was hypothesized by Hazeguero et al. From France. So this is because of the atrial musculature which continues into the pulmonary vein, and as they go deep into the pulmonary vein, the electrical heterogeneity and complexity of this tissue increases, as shown in this autopsy specimens of 9 pulmonary veins. There are various kind of extension of atrial musculature into the pulmonary vein. So these provide the trigger, and after trigger, how AF is sustained. So classical AF mechanism is like one ectopic focus. Sometimes what happens is we are ablating the AF, and when we are isolating one particular vein, the AF terminates. So these kind of ectopic foci are called drivers. These are AF drivers. So if you find an AF driver while doing an ablation, you are lucky that you take care of this driver and AF terminates. Then a single circuit re-entry can sustain AF, and multiple wave re-entry. These elliptical re-entry waveform is called rotors. So there can be a single rotor and there can be multiple rotors. So there can be a single rotor acting as a driver, and there can be multiple rotors sustaining the atrial fibrillation. And there is epicardial and endocardial dissociation also, more in case of atria. So it also helps in sustaining the atrial fibrillation. So these are the mechanistic concepts. Why we are discussing is that they help in the ablation. So treatment strategy, rate control versus rhythm control, I don't think it's still a controversy. We have very clear in our mind that which patient goes for rhythm control and rate control, despite the confusing data from the RACE, AFFIRM and other trials. Rhythm control should be targeted for paroxysmal AF and young age patients. symptomatic, persistent or long-standing persistent AF, symptomatic, and associated heart failure. These are the patients who are the candidate for rhythm control. I'm telling with evidence, rate control, permanent AF, old age, asymptomatic, persistent or long-standing persistent AF, people not suitable for drug therapy or ablation therapy for rhythm control, they are the candidates for rate control. So rate control is done by drugs like beta blocker, calcium channel blocker, digoxin, and then AV node ablation with permanent pacemaker. Rhythm control best done with class 1C drug or class 3 drugs, cardioversion, radiofrequency ablation, cryoablation. These are the technologies for rhythm control. So what basically we need to do is we need to do rate control with AV node blocking agents. Rhythm control, we have to work around the rhythm in generating in the left atrium, and stroke prevention is very important. We have to take care of this complex structure called left atrial appendage. So once a diagnosis of AF is made, then we do risk stratification for stroke and start anticoagulation irrespective of what stage, what classification it is. If it is paroxysmal AF, we go for rhythm control. If it is persistent AF, we have choice either for rhythm control or rate control. And if we go to rhythm control and patient rhythm control fails, we can go back to rate control. If we go to rate control and the patient remains symptomatic, we can come back to rhythm control. And of course, in permanent AF, we have already decided that we will go for the rate control. So as far as drugs are concerned, I think when there is no structural heart disease, we should use flecainide, propafenone. These are the drugs available with us, or amiodarone if these two drugs do not work, or catheter ablation. But now for catheter ablation, it is not necessary that patient should be resistant to amiodarone. Amiodarone is not in that class. If patient is not responding to class 1C drugs, you can go for the catheter ablation, because amiodarone is as toxic or maybe having more side effects than. So these latest trials of atrial fibrillation ablation have not included those patients who have failed rhythm control on amiodarone. So it's still a good drug, but it cannot be practically, it cannot be continued for years together in a single patient. We all see day and so if patient is having structural heart disease, we have less options and we are left with amiodarone. Dronedarone is not available anymore for catheter ablation. So CHAD-VASc score we all know, and we decide the anticoagulation with the help of CHAD-VASc score. Catheter ablation, the advantages of catheter ablation, whether it is cryoablation or radiofrequency ablation, is more freedom from atrial fibrillation, more effective in improving symptoms. Disadvantages are that these are expensive therapies, high recurrence and repeat procedures are needed in a very good number. Procedure related complications are still there, high skill set is required, and it probably does not improve long-term outcome. So it just improves symptoms. So in paroxysmal AF, the ablation approach is to take care of the triggers, and in persistent AF, trigger versus, these are the single procedure success rate for paroxysmal AF. In this chart, very initial experience of cryoablation is considered, but now the cryoablation is non-inferior to the radiofrequency. Kansal AF was a trial which established that catheter ablation of atrial fibrillation in patient with heart failure was associated with significant lower rate of composite endpoint of death from any cause or hospitalization due to worsening heart failure. So any patient who is cardiomyopathy, dilated, ischemic, non-ischemic, and if patient has non-valvular AF associated, we should try and do ablation for this AF because it improves the mortality. So this is one indication where it is approved as class 1. These are few ablation trials. So they all reduce cumulative AF burden, but not exact mortality. The Kavana trial also suggested that it doesn't reduce the primary endpoint as all-cause mortality, but results were affected by crossovers, and ablation significantly reduced mortality or CV hospitalization, 17% compared to drug therapy. There was also a significant 47% reduction in recurrent AF with ablation compared to drug therapy. So there are there are evidence that help. So now this is the latest thing, cryo, which we are going to talk in more detail. There is some evidence attached to it. These are the 3 trials of cryoablation with some good results. I think Dr. Kush will also take this into account. So it also definitely improves quality of life and symptoms. So as the guideline also we'll discuss that the it has been for improvement in the quality of life to treat symptomatic AF, catheter ablation is the key in comparison to drugs. So this is the just overview of the cryoablation instruments. I think we'll go into details. So last, to finish with, what is integrated approach to AF management? So this is something like AF clinic. We are running a good successful heart failure clinic, and maybe if God willing we'll start AF clinic also. But this is very good concept that it is not a single person managed thing, atrial fibrillation. So medical model versus integrated care model. What is medical model? Medical model means patient comes to the consultant, he does some test, and then he applies his own mind and gives some medication and tell him to do some tests periodically and see, look for whatever he wants. But integrated care model is when uh, there is AF nurse, and then family is also counseled and educated about atrial fibrillation. Then cardiologist, of course, then pharmacist and general practitioner is also involved. And then to manage the comorbidity, there are other specialties which are managed. So the integrated pathway believes in ABC pathway, AF better care, or ABC pathway, A for anticoagulation, avoid stroke, B better symptomatic management, and C cardiovascular and comorbidity management. So this is the ABC of AF management, which can be taken care better by the integrated approach, where there is a AF clinic kind of setup, and there is integrated approach with the team to recognize, treat, and manage the atrial fibrillation. Thank you very much.
What is the current status of AF ablation, the ablation in the management of atrial fibrillation?
Sir?
What is the current status of ablation in AF management?
If I think we take the guidelines also, next talk is on guidelines also. Guideline has also already approved AF ablation for symptomatic AF, those who are resistant to class 1 drugs, the
Yeah.
AF ablation, and also with heart failure.
Yeah, so it is class 2 indication. Basically, class
Yes.
1 it's not the class 1 indication, except few cases you say. And yours, one of the slides you highlighted that patient like those who have those who do not have a heart failure drugs. What about the patient who have LV dysfunction in AF?
Yes, LV dysfunction and AF. If we think if AF, then again, whether LV dysfunction or not, we'll take decision according to the AF status, whether it is paroxysmal, persistent, or long-standing persistent AF. Up to long-standing persistent AF for heart failure with LV dysfunction, people are doing catheter ablation. But if it is paroxysmal AF leading to decompensated LVF, then definitely it's a good idea to do catheter ablation.
What about somebody is known patient who has LV dysfunction and he develops atrial fibrillation? What is the difference in the management?
Pardon?
The patient is known case of it's not the AF cardiomyopathy because the AF. Somebody has known case of LV dysfunction and he develops AF later on.
Yeah, so AF as a comorbidity, you mean to say. AF cardiomyopathy, of course, it would be the absolute indication to do the rhythm control. But if it is LV dysfunction and then patient developing AF, then it depends. If patient is having symptomatic episodes of AF leading to deterioration and coming with acute decompensated heart failure, and even if not that, with LV dysfunction, heart failure, the the Kansal AF trial says that it improves overall mortality. So these patients should be taken up for ablation. But definitely these patients need a better skill set, aggressive ablation in form of substrate modification also, not only PVI. But yes, only PVI also if we do, it will reduce the frequency of AF and reduce the burden of AF.
Congratulations, Jitendra. You have shown one beautiful slide, substrate and trigger. And in that, you mentioned the origin of atrial fibrillation is more from the pulmonary veins. So, how you differentiate whether these APC originating from LA, from PV, or from SVC, IVC? First. Second, you mentioned if it is originating from RA, you have to control the rate. And if it is originating from the LA, you have to control the rhythm. So, how is this?
No, even if it like, okay, so I understand the question. One thing is that patient is presenting with paroxysmal AF. We haven't recorded any isolated PACs. Okay. There it is very difficult to say that from where it is coming actually, because patient has ECGs of paroxysmal AF but not ECG showing a isolated APC. Okay. Then if we take him for ablation and then we notice that there is a PAC triggering the atrial fibrillation, then we have catheters in place and we can find out with the help of catheter mapping like TS catheter and RA halo catheter that from where it is coming. But if there is frequent PAC, APC coming during the EP study, we can do a 3D mapping and find out exactly from where it is coming. But if you see a focus either from right atrium or left atrium and it is starting an AF, the idea is to eliminate that trigger, whether it is coming from SVC or it is coming from an azygos vein or it is coming from an IVC or a ligament of Marshall within the coronary sinus. So from wherever, if we find a clear-cut trigger, we are very happy that, okay, let's take care of this trigger and then we are done. But sometimes, like this case we are presenting today, this lady had ECGs of APCs also very frequent and then atrial fibrillation also. And during isolating left superior pulmonary vein and then left inferior pulmonary vein, probably that was driving the AF and then AF terminated on table. We'll show you that. So if patient is coming with paroxysmal AF, we take it granted that pulmonary veins are the source and we isolate the pulmonary vein. So pulmonary vein isolation is the basic thing we do. Then if we see some other trigger also, we take care of those.
Without doing the catheterization, is there any source by which we can differentiate? ECG you can differentiate
Yes,
RA
yes.
or
Yes,
and
yes.
second thing, whether we have to control the rate on the RA APC or rhythm for the LA APC. It is like
No, that rate and rhythm control is not for APC. Rate and rhythm control is for AF,
That's
not for APC. APC leading to AF, I would any day like to ablate it. APC leading to whether it is right atrial or left atrial.
or AHI.
And if surface ECG is there with good P wave associated with an APC, we can easily find out RALA. It is sometimes difficult whether it is coming from left superior pulmonary vein or left inferior pulmonary vein or mitral annulus. But RALA is easy.
how frequently the APC is going to AHI, IRI, what definition you mentioned, and then following the atrial fibrillation, is there any incidence data?
In almost all cases of paroxysmal AF, more than 90% of paroxysmal AF cases, the ectopic, the trigger is coming from pulmonary vein. Rest 10% all put together. And big chunk of them is atrial flutter. So that's why people do cavotricuspid isthmus ablation also as part of AF, because atrial flutter is also one of the very common triggers. But SVC, IVC, they are very rare triggers and isolating them is a hell of a job, so nobody is doing.
If you have a asymptomatic patient with multiple APCs, you can find the site of origin. Would you like to ablate them? Multiple asymptomatic APCs.
No, multiple asymptomatic APC is something like
Precursors
multifocal,
of AF
yeah,
ultimately.
multifocal atrial tachycardia. So no, I would not like to. In asymptomatic patient, no.
They are precursors for the
Yeah, they are
future
precursor for
AF,
AF. If AF is happening, yes, we can do pulmonary vein isolation, and then maybe according to the LA structure, some substrate modifications, some mitral annulus, mitral isthmus block or LA roof line or that. But it is very difficult to ablate 3, 4, 5 APCs coming from different sites. Very difficult. And it's very uncommon clinical scenario.
Unifocal atrial premature beats if you have the old ECG with you in asymptomatic phase. Would you like to go?
No, no. Asymptomatic atrial premature beats, no need to ablate. Symptomatic atrial premature beats, yes, we have done that. And generally they come in form of runs. So we need to look about the anticoagulation also sometime in high Chadwell score. But asymptomatic atrial premature beats, or for that matter ventricular premature beat, we don't ablate. But we more commonly we ablate symptomatic ventricular premature beats than atrial. Ventricular premature beat have more chances of having symptomatic.
Dr. Makkar, it was a very nice presentation about atrial fibrillation. I feel atrial fibrillation, as long as it is symptomatic, needs to be treated. Which direction we need to go is very well presented by you. Asymptomatic APCs, we all know, is most likely secondary to respiratory pathology than any other things. So we don't really need to go after them. That is what you have already pointed out. Most of the times APCs which need to be treated are the ones which come in runs, and they are usually the ones coming from pulmonary veins. So that is what we usually target. That is exactly what you have said. PVCs have a tendency to cause LV dysfunction. That is why we go after them. Otherwise, they also don't really need any treatment.
Exactly.
I think we should go to the next topic and then go ahead and discuss AF further.
One practical scenario, one 65-70-year-old female having AF and turns out to be hyperthyroid, and she is also hypertensive, systolic hypertension isolated. If we control, you become euthyroid, give just beta blockers, she becomes in sinus rhythm. As per the age and hypertension, she is having chest VASC of 2 in the range for recommendation for anticoagulation. So even after she is having euthyroid status, sinus rhythm, does she require a lifelong anticoagulation when she becomes normotensive also?
No. If we see the flow chart of latest guidelines, then just like bradycardia, it is written reversible cause for atrial fibrillation. So if there is reversible cause for atrial fibrillation, then there is no need. But then we have to apply our clinical sense that hyperthyroidism was the sole issue. In this case, if looking at her age, I would like to do screening for asymptomatic AF even after you have treated the thyroid. Maybe 1 or 2 Holter or 1 or 2 7 days patch monitoring, which is very easily available these days, should be done to rule out asymptomatic AF despite treating the hyperthyroid. Yes.
What is the first line treatment of paroxysmal AF? Will it pocket therapy or just ablation?
Yeah, I think we are coming to guidelines, so we'll be able to discuss more clearly after this. I think we should go through the guidelines. Next talk is guidelines only. So, but it is first line therapy. It's not never a first line therapy, but for symptomatic paroxysmal AF, and if there are high chances of having side effects by the drugs, it can be used. There are some trials which show that if it is used as a primary first line therapy, it reduces the recurrence of atrial fibrillation, it reduces the AF burden, it improves the quality of life, but there is no data that improves mortality or long-term outcome. So first line therapy, yes, it can be used for very symptomatic paroxysmal AF, those who are not willing to take drugs and they are very symptomatic and very frequent.
Sir, one more question. Is there any criteria to decide ablation in paroxysmal AF? Like how many episodes in a year of paroxysmal AF we should go for ablation?
No, symptomatic, even one episode of symptomatic atrial fibrillation, despite uses of class 1C drugs like propafenone or flecainide, one can go. That's what guideline says, but then it is the mutual agreement between the doctor and the physician and the patient that whether he wants to go for ablation or not. There is no criteria of AF burden related to AF ablation.
And sir,
It's all about symptoms.
And sir, just like paroxysmal AF is having chats VASI score either 0 or 1, and there is no need of anticoagulation in such cases in paroxysmal AF. So, matlab, as you said, it is for quality improvement. So it prevents stroke also or not?
No, no, no.
Ablation.
AF ablation doesn't prevent stroke. Clear statement. Anticoagulation, even after ablation, we need to rule out, just like hyperthyroidism, we need to rule out silent F. It only reduces symptomatic AF episodes. We have to rule out asymptomatic AF episode. So whenever we are doing ablation, we should not tell the patient that your stroke risk will reduce. Never.
And sir, if CHATS score is more than 2, so we have to anticoagulate the patient.
Yes.
Then we need ablation.
These two are different things.
Okay.
The ablation depends on symptoms and anticoagulation depends on CHATS score. That's it.
Thank you,
Atrial
sir.
fibrillation ablation trials which were conducted later on with Holter monitoring post ablation, and
Yes.
I'm talking about catheter ablation, radiofrequency ablation. They showed multiple episodes of asymptomatic AF still happening in those patients.
Yes.
Symptomatic AF vanishes. God knows what is the reason. Maybe all the nerves which are around that basically gets ablated, and therefore the symptomatic episodes goes off. So you should never say that you can take the patient off anticoagulation. They have done it if they have shown that AF has not recurred in a patient for more than 3 months, then they stop it. But then they still have risk of stroke post ablation. 3 months तो देना ही देना है. उसके बाद आप decide कर सकते हो.
Then CHADVAS
Yes.
CHADVAS.
Of course, looking at the CHADVAS. But if CHADVAS is even 0 and 1 and you have done an ablation, you have to anticoagulate for 3 months anyways.
Yes.
Just last question. But if you look at the discrepancy in the Cabana and other trials, it was because of the stoppage of the anticoagulation that led to difference. So you have to continue the anticoagulation, prevent the stroke or the
Understand
second.
anticoagulation and symptomatic atrial fibrillation management are two different things.
Yes.
Anticoagulation doesn't depend on your ablation.
Yes.
Anticoagulation may need to be continued lifelong in some patients, even if you have done your atrial fibrillation ablation.
Yes.
Jitendra, last question. Na?
Yes.
How costly this cryoablation for atrial fibrillation?
Costly. We are charging 7.5 lakhs. So, but in यहाँ पता नहीं बताना चाहिए नहीं बताना चाहिए दिल्ली में one center was charging 12.5 lakh rupees. So this actually this Arctic balloon catheter costs a lot. It is around 5 lakhs. Cost is around 5 lakhs. So put, yeah, and it's all of course single use. So right now we are not earning out of anything out of it. The only earning is probably our self satisfaction. Thank you so much. Thank you. So next is AF guidelines. What is new? And this will be presented by our young champion, Dr. Kush Kumar Bhagat.
Thank you so much, sir, for such a wonderful discussion and wonderful presentation. So it was thank God sir was the first presenter, so all the questions were asked from sir. Otherwise, it would have been very difficult for me to answer all these questions.
No problem. I think you can answer better than me. So I'll invite the chairpersons for your talk. Dr. Dinesh Choudhary, who has come all the way from Bikaner. Thank you, dear. Dr. Milind Srivastava, always blessing us with his tiny hands. And Dr. Sanjeev Sidana, my childhood buddy. Dr. Dinesh Gautam is here. I think there's something going on, some Fagun Utsav in SMS. Dr. Ram Chitlangia, not there. Dr. Sunil Garsa, Dr. Suvir Gupta, Dr. Prem, can you come? Thank you. So you can.
So I think from the first discussion, I could see that guidelines are very important to discuss. So actually, there are two guidelines. one is ESC guidelines and one is ACC-AHA guideline. So ESC was released in 2020 and ACC-AHA was, I think it came in 2017 and updated in 2019. So before starting my presentation, I'll ask two questions basically. So I'll present two cases, and then we will discuss the guidelines. So first case is a 45 years old male patient, history of recurrent palpitation. And ECG was done and it was documented to be a case of paroxysmal AF, which was reverted back to normal. Echo was normal and he was on amidron beta blocker and obviously anticoagulation. And he had, despite treatment with beta blockers, amidron, he had recurrent symptomatic episodes of paroxysmal AF. So question is, what should we recommend? So patient had recurrent episodes of paroxysmal AF and these are symptomatic despite medications. So what should be the line of management? Any input, or should I discuss it maybe after presentation? Fine. So first was this question, and second question is a very interesting question, which actually these kind of cases we see in our day-to-day life. So he's a 60 years old male with no structural heart disease. He had recurrent symptomatic paroxysmal AF episodes and which were treated with beta blockers. Patient presented with frequent dizziness, and basically this is the ECG strip. And whenever patient had atrial fibrillation, whenever AF terminated spontaneously, he had a sinus pause, and then the normal beat came. So symptomatic post-conversion pauses were there, and the diagnosis was made as tachybrady syndrome. So the question is whether patient needs permanent pacemaker implantation. So what should we recommend? Either a permanent pacemaker implantation and continue beta blockers, PPM and add antiarrhythmic medication, just reassurance, or AF ablation. So I think I'll start my presentation. So I think sir has already mentioned this slide, the paroxysmal persistent. Just one thing I would like to add, that in persistent AF, there are basically two classifications: early persistent AF and long-lasting persistent AF. Early persistent AF is AF episodes sustained more than 7 days, but less than 3 months in duration. That's the same. Now, why should we actually treat atrial fibrillation? So, because actually, if we talk about the outcomes, then there are high chances of death, stroke, progression of AF to heart failure, LV dysfunction. There can be cognitive decline, vascular dementia, depression. Most important is impaired quality of life, because a lot of patients, young patients, come to emergency with recurrent paroxysmal AF and actually need hospitalization for a day or two to revert back to normal sinus rhythm. So coming to the guidelines without wasting much time. So indication for catheter ablation of atrial fibrillation. So patient who is symptomatic or who has symptomatic AF, refractory or intolerant to at least one class 1 or class 3 antiarrhythmic medication. So guideline says that basically for paroxysmal AF, if patient has been prescribed antiarrhythmic medication and despite that patient has symptomatic AF, it is actually a class 1 with level of evidence A indication. So it's a class 1A indication for any patient with paroxysmal AF who has recurrent episodes despite medication. So very, very strong evidence. I think class 1 level of evidence A is very strong recommendation. So this was the paroxysmal AF. And if patient has persistent AF, then it becomes a class 2A indication. Long-standing persistent becomes a class 2B indication. So paroxysmal AF, recurrent episodes despite medication, class 1 level of evidence A. Now, so this is after starting either class 1A or class 3 antiarrhythmic medication. Now, second is symptomatic AF patient prior to initiation of antiarrhythmic therapy with either class 1 or class 3 with paroxysmal is still class 2A indication. That means that any patient with paroxysmal AF who is symptomatic, so we can actually go for catheter ablation with a class 2A recommendation, which is also a strong recommendation with level of evidence B. Now, but if patient has again persistent AF, then again it's a class 2A recommendation. Long-standing persistent, it's a class 2B. So I think this is quite clear that for paroxysmal AF patient, we can actually go for catheter ablation even without starting antiarrhythmic medication with a class 2A recommendation. But most important thing is that patient has to be symptomatic. So all this is for symptomatic patient, because if patient is asymptomatic, then for paroxysmal AF, it can be considered, but the class is class 2B indication. One more indication I would like to stress, the tachybrady syndrome. So it is reasonable to offer AF ablation as an alternative to pacemaker implantation in patients with tachycardia syndrome. And it is also a class 2A recommendation. Again, it's a very strong recommendation. So for tachycardia syndrome, we can go for atrial fibrillation ablation with the class 2A recommendation. I think rest of the things are not significant. Now, so this was for catheter ablation, which it can either be radio frequency or cryoablation. So there are a lot of indication for surgical ablation for atrial fibrillation. I don't know whether our surgeons are sitting or not, but yes, if we talk about guidelines, so if we are basically opening the heart for either mitral valve surgery or by PABG or AVR, and if patient has either paroxysmal AF, persistent AF, long-standing persistent AF, be it whatever, basically the indication is class 1 indication. That means that any patient who is undergoing surgery and who has atrial fibrillation, they should be with class of recommendation 1. They are basically candidates for surgical ablation for atrial fibrillation. I don't know whether we do it or not, but yes, as far as guidelines are concerned, they are basically class 1 recommendation for surgical ablation for atrial fibrillation when we are opening the heart for mitral valve surgery or bypass surgery or AVR. Now, if we are not opening the heart, not opening the heart for any other reason, for bypass AVR or MVR, then if we talk about paroxysmal AF, then stand-alone surgical ablation, it can be considered with a class 2B. So it's not a good recommendation, but yes, if patient has persistent AF, then stand-alone surgical ablation is reasonable for patients who have failed catheter ablation, or basically they are intolerant to medicine, or they have recurrence despite medicine, with a class 2A recommendation. So it's a very strong recommendation for persistent AF, surgical ablation of atrial fibrillation. But I don't think that in India lot of surgeons do AF ablation. So coming to my question, so what will you recommend for these patients, sir? Patient has tachycardia syndrome, and we know that the causes are when patient gets terminated. When patient gets terminated from atrial fibrillation. So should we go for pacemaker implantation or should we go for AF ablation? Class 2A with AF ablation, but yes, again pacemaker implantation is also an option. But still, if we go for AF ablation, then we are justified. But then we have to be sure that this syncope or whatever this syncope is there, that is because when the AF terminates and there is a pause. And if we demonstrate that, then definitely we can go. But then if there is sinus pause without related to AF, then definitely we have to go for pacemaker. Yes, age is a big concern. So,
Kush, I would like to ask one question. It is a class 2A indication.
yes, sir.
But in tachycardia syndrome, mostly present to us with syncopal episodes, not with the tachycardia problem. So, how reasonable it is to subject these patients for AF ablation, which is a much costlier procedure as compared to a pacemaker implantation.
You're absolutely right. But I'm just talking about guidelines. So practically,
why we have to discuss
I think
that.
hardly anyone go for AF ablation for these procedures. Definitely, pacemaker implantation is much more safer.
Yeah. So I think it is a clinical decision where 2-3 things are very important. One is age. In a young patient, you would like to avoid a pacemaker, so we can tell them that we can try AF ablation first. That is one thing. That this case was young, 45 years. 60. So at 60, I would like to go for pacemaker. Second thing is to analyze the Holter very carefully. If there are independent episodes of bradycardia and tachycardia, it is better to go for a pacemaker. But if most of the poses are at the termination of atrial fibrillation episode, then this ablation is going to work. But then it is for time being only. This is just the natural history of sick sinus syndrome, that it will eventually terminate, require a pacemaker lasting as bradycardia.
So, what about this patient? Gaurav sir, would you like to answer this question? I just had a discussion about this question. A 45 years old male patient who had recurrent episodes of paroxysmal AF despite medication. So, what will you recommend, sir? He's fitting all the criteria for NOACs. Maybe CHAD-VAS score is more than 2. So, we are giving NOACs to the patient. No doubt about that. About the therapy, I mean to say. So, this can happen, sir. A lot of patients are there who have episodes despite medications. We can, no sir. So paroxysmal, again, for any AF episode, be it paroxysmal persistent, early or long-standing or permanent, you have to give. It all depends on the CHADVAS score, not whether it's paroxysmal, persistent, or long-standing or permanent.
So if 45-year young male, healthy male, no structural abnormality, no non-hypertensive, non-diabetic,
Sir,
non-heart failure, then
That's why I corrected that he met all the criteria for CHADVAS score.
so what is the score? What is the score in this case?
Yes, we have to give for anticoagulation if we are going catheter ablation. Definitely we could differ. So basically, anticoagulation and radiofrequency or anticoagulation and catheter ablation are basically two different things.
Yes, but my one point, if patient is not on anticoagulation and he is having proximal AF and recurrent in spite of drugs, so we would recommend catheter ablation in which he will take 90 days oral anticoagulant therapy. Okay, thank you.
So okay, if we talk
3 months post ablation.
So basically, this is how we isolate the pulmonary veins. So these are the 4 pulmonary veins. I mean, this is, I think, right, left superior, inferior, right superior, inferior. And these brown dots are the radiofrequency ablation dots. And this is how we isolate these pulmonary veins. As Sir said, that pulmonary vein isolation is actually a cornerstone of, the AF ablation strategy. So again, this was the guideline on the when and how to choose the patient. And coming to the strategy of AF ablation, so pulmonary vein, as I mentioned that according to HRS consensus statement that more than 90% of AF triggers are found near the pulmonary veins. I think GL Sharma sir has left. He asked a very important question that suppose a trigger came from the right side of the heart. So there are cases where suppose a trigger is exclusively from the right side of the heart. They just ablate the trigger in the right heart and don't do pulmonary vein isolation. Then patients can become free of atrial fibrillation. So there are case reports that just by removing the trigger in the right side of the heart, we can go for, we don't need for pulmonary vein isolation. But yes, most of the triggers are in the pulmonary veins. So we should go for pulmonary vein isolation. So again, it's a class 1 with level of evidence A. So PV isolation by catheter ablation, it's a class 1 with level of evidence A recommendation. And non-ablation strategies to improve outcome, just weight loss, correcting sleep apnea, all these strategies should be considered along with the catheter ablation. Now, EAC 2020 guidelines, so most of the things are same. Just that it has actually given class 1 recommendation for any patient with paroxysmal AF, persistent AF. So basically, ACC AHA had 2A recommendation, but ESC guideline has class 1, more stronger evidence if we talk about EAC guidelines. And second, sir has already mentioned most of the things. Just one thing I would like to recommend this slide. So AF catheter ablation, it is recommended to reverse LV dysfunction in AF patients when tachycardia-induced cardiomyopathy is highly probable, independent of the symptom status. It's a class 1 recommendation. But we have to make sure that this LV dysfunction is because of tachycardia-induced cardiomyopathy. Like sir said that if patient already has LV dysfunction and not develops atrial fibrillation, then probably this level of evidence is, class of recommendation is not there. But if we know that it is because of tachycardia-induced cardiomyopathy, it's a class 1 recommendation. Still, it should be considered in AF patients with LV, with the impaired systolic function to improve survival and heart failure hospitalization. This is class 2A recommendation. Very strong recommendation for heart failure patients with, heart failure patients with atrial fibrillation. And rest of the things are same. I think I made my presentation short already. Any questions?
Kush, what I got from your presentation that we have to ablate the AF with pulmonary vein isolation.
Yes, sir.
So any criteria in clinically ECG wise that this patient should not go for the pulmonary vein isolation?
No, sir. PV isolation you have to do in all the cases. You are taking patient on table for atrial fibrillation ablation, you have to isolate the pulmonary veins. Apart from pulmonary vein isolation, there are a lot of other things which we can do for AF ablation. That depends on patient. Depends on the LA size, if it's a very large LA, as sir mentioned about the substrate, the triggers, so a lot of times it's not only the pulmonary veins which are responsible for AF.
So basically 8 to 10% cases, there may be that pulmonary isolation may be fail or something.
Yeah. Yes.
So we'll have to isolate the pulmonary vein, then we have to wait. Because 90% cases, the cause is the pulmonary vein trigger in the
all is pre-decided before we are going for ablation that what kind of strategy we are. We cannot wait just like other SVTs and it will flutter. What we'll do is in paroxysmal AF case, if heart is structurally normal, LA is normal, the PV isolation is just the only thing we need to do. Other, if we see some ectopics coming frequently from some other sources, we need to take care of that. Otherwise, things are done. In persistent AF or in long-standing persistent AF, if particularly if atrium is dilated, then we have to do other things. And what we can do in other things is the substrate modification. Substrate modification is done by 2-3 things. One is the just applying a line of block at the mitral annulus. Okay, that is called mitral isthmus. One is LA roof line. These two are most common substrate modification. Third commonest is the ligament of Marshall ablated from within the coronary sinus. So these are the most common things. And one concept which came and then faded away is CAFE, complex fractionated atrial electrogram ablation, CAFE ablation, which was given by one American, no, not Hazigure. CAFE was by, and I forgot the name, American guy. So this complex fractionated atrial electrogram, while we are doing mapping during the atrial fibrillation, will tell us about the area which are enabling the AF to sustain. They are acting as a substrate, isthmus around which the rotor is rotating. So those complex areas we need to ablate. And in some cases, when there is suppose nocturnal atrial fibrillation which is related to the vagus nerve, then we have to take care of the parasympathetic ganglia ablation. So there are a lot of things in substrate modification which depends, as Kush said, on patient to patient. But pulmonary vein isolation is the crux of AF ablation, which needs to be done in all cases.
It is on the right atrium, and still you have to go for pulmonary vein ablation. If you have seen that it is coming from the right atrium.
Very, very rare. Hardly I have ever.
It is very rare, I know, and mostly it is found in the patients who are having pulmonary disease, where
Yes.
you will get the focus on the right
Yes.
atrium.
If
But
I
as
get
per
a single,
protocol,
very hypothetical scenario where if I get a single PAC coming repeatedly from RA appendage and leading to atrial fibrillation, and then I am doing that and AF is gone, very uncommon.
my question is, in that case, you have ablated that focus in RA. Still, you have to go for pulmonary vein isolation, or you leave it.
I think if it is paroxysmal AF, we should do that because आज RA से है, कल pulmonary vein से होगी. Pulmonary vein are the sources of abnormal electrical activity. If we have gone for this, if we charge the patient, if we have done everything, we should ablate and do PV isolation.
Practically all the patients are, if patient is on table, then PV isolation will be done. But yes, there are a lot of times triggers are there, sir. SVC, mostly in the SVC. So we go there and ablate those triggers also. The complications, most
Sir,
of
if
the
you are
time.
going for atrial fibrillation ablation, pulmonary vein isolation is a concrete part and will always be a part of it. If you're not going for atrial fibrillation ablation, then you're going for a PAC ablation. Then it's a totally different issue altogether. But if you're going for atrial fibrillation ablation, PVI isolation is the first step. Followed by that, if the patient doesn't go into atrial fibrillation, we stop there, come out, and wait for a recurrence and then redo a procedure where the first step is again checking for pulmonary vein isolation if it is complete or they have broken through. If they have broken through, you have to do a redo pulmonary vein isolation. That is the first step in redo procedure also. During the primary procedure, what you can do is you can give adenosine, high dose, to see from where particularly the PACs are coming. So we have a catheter in SVC, we have a catheter in coronary sinus, we have a catheter in pulmonary vein. So we are able to find out where exactly this particular thing is happening. One ablation catheter is on the right side, the halo catheter is on the left side. So you're able to find out from where the PACs are coming after adenosine, and you can actually go ahead and further give further ablations to fortify the pulmonary vein isolation. So what you should understand is atrial fibrillation ablation is equivalent, almost equivalent to pulmonary vein isolation until unless you have to go for substrate modification.
Is the cryoablation most effective treatment for the AF?
So that will come in next.
No. Okay.
So I am talking
No,
about the
just-
catheter ablation. So this is just the guidelines about either it can either be RFA or cryo. Now the advantages and disadvantages of cryo, like we mentioned, that suppose if we have already done PV isolation and we now see that there are other triggers present in either LA roof or mitral isthmus or anything, we can't do cryoablation. We have to go for radiofrequency. Then we have to make it a hybrid procedure, cryo plus radiofrequency ablation. Yes, sir, we can. But yes, sir, we can definitely. Yes, sir, we can definitely isolate. We can recognize by the ECG whether it's coming from the left side or right.
You can isolate, yeah,
Pulmonary vein, left pulmonary vein or right pulmonary vein.
from ECG you can find out the site of trigger if you have APCs. But most of the times those PACs would be falling on the T waves, so you don't really know most of the times. So it is easy when we are doing ablation because we have catheters everywhere.
But then practical significance is nothing but because
Yeah,
we have to
even
go
if-
for PV isolation anyhow.
Yeah, even if you have one PAC coming from superior pulmonary vein, left superior pulmonary vein, and that is starting the, atrial fibrillation all the time, you still have to isolate all the four veins.
Pulmonary veins are more common sources, right superior and left superior than inferior.
What is the upper limit of LA to say that the heart is structurally normal?
I think we're talking about echocardiography. Sir, 4, if I'm not 4 millimeters.
4 centimeters.
What should be the
Let me tell you, that's not the hindrance to the catheter ablation. It can be done in a large LA also, but it depends more the how patient is behaving. Patient is still behaving as paroxysmal AF. I would like to do it even little bit enlarged.
In fact, in heart failure patients, I said this is the guidelines, class 1, class 2 recommendation for heart failure patients with decreased ejection fraction. Most of the times LA will be dilated in these patients, but still the guideline is class 1, class 2. So dilated LA is not a contraindication, but just that maybe only PVI would not be successful. We might have to go for substrate ablation as well.
पहले मुर्गी हुई या अंडा, ये तो बहुत मुश्किल है कई बार. Sometime it is. Yes. Yes.
Difficult to say, sir.
So look at this guideline. They says that cardiomyopathy is highly probable. So any tachycardiomyopathy, the diagnosis is too retrospective. When you have taken care of tachycardia and LV dysfunction reverses, then you say that, oh, it was atrial tachycardiomyopathy. But if we haven't seen any ECG showing sinus rhythm and patient had definitely AF before LV dysfunction happened, then maybe we can say this is still we are not sure unless we do rhythm control by ablation or drugs and see the reversibility of LV function. It is very difficult actually. Or we can do this cardiac MRI and look at the atrial fibrosis. So maybe if fibrosis is there, it goes more in favor of structural heart disease, and then AF as a side bystander. And if it is no fibrosis, only dilatation, that in favor of. But this is a very rough criteria, not a definite.
I think we should end this session.
thank you.
ओके, तो चलो आप आज की दुल्हन के दर्शन अब कराते हैं आपको. आफ्टर ऑल दिस डिस्कशन, द cryo balloon. So Kush will again present the new frontiers in management of AF, the cool way to treat. So I'll request chairpersons, to- Dr. Atul Kasliwal, both, Dr. Amit Churasia, Dr. Gaurav, Dr. Gaurav Singhal. Was there. Uh, Sanjeev Roy was is there. Dr. Sanjeev Roy. माथुर सर, RM माथुर सर, प्लीज प्लीज कम सर. आप यहाँ बैठेंगे तो ब्लेसिंग्स मिलेगी सर हमें. प्लीज प्लीज सर. डॉक्टर प्रेम, तू कहाँ चला गया भाई? आ जाओ आ जाओ आ जाओ, 4-5 लोग तो बैठो. हाँ? डॉक्टर ललित गर्ग, प्लीज कम.
Thank you so much, sir. So I'll again keep my presentation short since we are lagging behind in time. So I have already discussed that what are the implications of atrial fibrillation. Now the question is, why do we need to treat AF at an earlier stage? So earlier stage means that before it progresses to persistent AF, long-standing persistent AF, or uh, that basically we should treat the AF episode as early as possible and in the paroxysmal AF stage only, because AF is a progressive disease and earlier treatment is important. And after 12 years, 50 to 77% of patients receiving medical management will develop persistent or permanent atrial fibrillation. And progressive AF is actually, progressive AF is, will lead to more significant risk of heart failure, risk of hospitalization, higher risk of stroke, higher risk of death in patients with persistent and permanent AF versus paroxysmal AF. Again, more chances of stroke and decreased quality of life. So basically, the important thing is that we have to treat AF at an early stage, at the paroxysmal AF stage. Because as the AF will progress to persistent AF, long-standing persistent AF, then the chances of success rate will be less and probably the chances of recurrence will be high. So coming to the strategies of AF ablation, basically we have two strategies I have already discussed. One is the radiofrequency ablation and the cryo ablation. Cryo means the cool way, and radiofrequency we are giving burns. So, but the cornerstone therapy is same. We have to isolate the pulmonary veins. So we can do the isolation by either radiofrequency or the cryo ablation. So so this is how we isolate. I've already shown this slide. We are isolating the pulmonary veins. These are the brown dots. Now coming to the cryoablation. So basically, it's not a new procedure. Cryoablation is not a new procedure. Again, so I think we are. Outside India, it's been I think 10 or 12 years that cryoablation is being done. But India, it was recently launched. And these are the various trials, the cryo first trials, stop AF first, early AF, that has already mentioned. I'm not going to go in detail of these trials, but these were all recently published trials. And it has recently, this new catheter has recently been approved by US FDA with stop persistent AF clinical trial. And this is basically, so these studies have demonstrated that as a first line therapy, cryoballoon ablation is superior to antiarrhythmic drug for prevention of atrial arrhythmia recurrence. So all these studies have shown that even before you start antiarrhythmic drug, you can go for cryoballoon ablation as a first line therapy. And first line cryoablation is associated with larger improvements in AF specific quality of life compared to antiarrhythmic drug therapy. More patients were asymptomatic at 12 months following first line cryoablation versus antiarrhythmic drug therapy, and cryoballoon ablation as first line rhythm control strategy has an acceptable safety profile. So this was a trial which compared the radiofrequency ablation versus the cryoablation, the fire and the ice trial. So cryoballoon versus point to point radiofrequency ablation was compared, and it was shown in secondary analysis that cryoballoon ablation had fewer repeat ablations, fewer hospitalization, fewer cardioversions, and 21% decrease in reduction in all cause rehospitalization. And this is actually how the cryo balloon looks. So this is the basically balloon, and this is the mapping catheter. We call it Achieve catheter. And this is the console. So basically, this is the cryo console, which is expensive. And this is the balloon. So balloon comes in the two sizes, 23 millimeters and 28 millimeters. So this is basically the sheath through which this balloon goes. Again, this is the mapping catheter. I have already shown that this is the mapping catheter here. And this is again the various other catheters used for other arrhythmias, not for this atrial delay. So these four things are required for cryo ablation. And how basically we isolate. Now again, the main the main objective is to isolate the veins. So we are giving not burns, but we are actually freezing the tissue here with the help of cold, with the help of cryo balloon. So this is the cryo balloon in the deflated state, and this is the mapping catheter. This is the left superior pulmonary vein. So my catheter is this catheter is in the left superior pulmonary vein, and this is the balloon. So now this is the inflated balloon, and now we are just pushing this balloon in the pulmonary vein. So once the cryo balloon is in the place, so basically the cryo balloon, I'll just show in the next slide. So it removes the heat from the tissue for a more durable method of pulmonary vein isolation. And after ablation, we can demonstrate that all the pulmonary vein potentials, they have been disappeared and pulmonary vein has been isolated. I think Dr. Chitresh will take care of that. So basically, this is the console, and this is the mapping catheter, the cryo balloon. This is the sheath basically, or the catheter, and this is all the so liquid nitrogen, the pressurized liquid nitrogen, it is delivered from the cryo console through this tubing to the tip of the inner balloon, and inside the balloon the liquid nitrogen vaporizes and it absorbs heat from the surrounding tissue. So this console takes care of the safe delivery of nitrous oxide to the catheter and return of the warmed vapor, and it is scavenged out of this scavenging host. So this is how basically the system works. So we are freezing the tissue with the help of the, I think this is liquid nitrogen or nitrous oxide. So basically, what is the difference between cryo and radiofrequency ablation? So this is a pulmonary vein, and as I have shown, the dot by dot radiofrequency ablation, the burning the tissue with point by point radiofrequency burns. Again, we have to keep a mapping catheter both the cases, and we are giving the radiofrequency burns. This is the pulmonary vein, right, left superior pulmonary vein. Now this is again the same way, but we are not burning the tissue. We are basically freezing the tissue with the cryo balloon. So how will the the major difference, as Dr. Prem asked, what is the major difference between these? So as far as cryo ablation is concerned, it is comparatively simpler with short learning curve. It is very easy to reach the target area within the short time, and it has got a very predictable and very consistent results. A reduced risk of complications, fewer repeat ablations. So basically, and as far as radiofrequency ablation is concerned, it is technically more challenging, more time taking, more risk of complications are there, more chances of PV connections later on, and chances of repeat ablations are there with radiofrequency ablation. And the procedure times, methods, and results are all operator dependent, and they varies center to center. So this is how the lesion looks basically with the cryo and with the radiofrequency. We can see how ugly the lesion is looking with the help of radiofrequency. So after 1 week, there's a thrombus and disrupted endocardium. And at the end of 1 week, this is a well demarcated lesion. This is the tissue, and this is well demarcated with minimal thrombus, and endocardium is intact. So cryo adhesion improves the contact and stability. It preserves the extracellular matrix and endothelial integrity, decreases the risk of thrombus formation, and a well demarcated lesion is there. So it is simple, safe, fast, effective, and short procedure duration, which is very, very important in a busy cath lab. And it creates ideal lesions that are wide, extended, and more circumferential as compared to the radiofrequency, and fewer chances of repeat ablation. This is very important. And safety. Safety is again very, very, if we talk about the safety profile, then cryo balloon is much safer as compared to the radio frequency ablation catheter. Again, shorter learning curve and easy to adopt, and we have the results with us with the cryo balloon as well. So starting from the various balloons which were present, the various trials have already demonstrated the efficacy of the cryo balloon therapy for treatment of atrial fibrillation. So just to summarize, earlier treatment with catheter ablation has been shown to reduce atrial arrhythmia recurrence, and patients can now be referred for a cryoablation without the need for drug therapy failure. So all these three trials which were published recently, the US FDA has approved this cryo balloon ablation even before starting the antiarrhythmic drug therapy, although it has not been in the guidelines. So if we talk about guidelines, the class 2 I recommend. So it was recently launched in 2021. Recently, FDA approval we got even before starting the antiarrhythmic drug. Cryo. Thank you.
Kush, you mentioned that paroxysmal AF should be managed as early as possible.
Yes.
So, is there any deviation in valvular versus the non-valvular AF?
This is all about non-valvular AFs. I don't think that we are doing ablation for
So,
valvular AF.
any guideline that about the patient with this MVR going for MVR and the paroxysmal AF, and these patients should be treated early or something else by surgeon also?
How many patients you have seen of MVR with paroxysmal AF?
Because there
Very
will
rare, sir.
there will be the cardiac remodeling there, and definitely
Because
they will.
already exactly. So most of the times we are managing these kind of patients with medical therapy. So it's non-valvular AF and mostly paroxysmal AF or early persistent AF we are talking about.
These all guidelines are for non-valvular AF. Even these surgical guidelines are for non-valvular AF because they are all American where RHD is not there. In our case, if we are if doing surgery for atrial fibrillation and rheumatic heart disease and we are replacing the mitral valve, the maze procedure is only the answer with a limited clinical.
What is the recurrence rate of AF after this cryoablation? What is the incidence?
Less as compared to radiofrequency ablation, sir.
Percentage wise, what means?
Depends on the patient, depends on the procedure how we are doing, but yes, ranging from 10 to 30%. So
As you say that
Roughly, we can convince a patient that around 70% there are chances of free AF free period, good AF free period, 70%.
As far as we are talking about the surgical patient who are going the mitral valve replacement, you're right. We started with various Cox modification, Cox 1, Cox 2, then cut and sew. Though it looks very fascinating, that cut and sew, that definitely interrupts the pathway. But the complication of bleeding, and as he said, it may be 30% with this. Even with the Cox maze where you are cutting, you are sure that you have cut the path. The persistent AF incidence was quite high. Then came that we used to use this handhold RF catheters, not cutting the thing, and you used to do that. Even with that, the incidence was high. Basically, what happens in rheumatic disease that you have got fibrosis and all of LA, and LA is so enlarged. Unless you associate with what you were saying that you have to go around the annulus, mitral annulus, and all those also. In addition to that, you have to cut a sizable part of LA also, and that causes a lot of problems and issues. I think it's one of the good option. Maybe soon we will see that the surgeon is doing the replacement or whatever it is, and then it's being followed with this, or this followed by surgery.
Overall, it is very difficult to get rid of AF in a rheumatic heart disease patient. So there is hardly any research or any efforts are going on in that direction.
So are we doing surgical ablation nowadays?
Not really. It's gone down since you have taken all, and I think whosoever is doing will be deprived of this with the advent of these things. Problem is if you cut and sew, then there are a lot of chances of bleeding, and it takes a lot of time. So you may be decreasing the incidence of AF and all, but on the same time your bypass time and all that goes up. That adds to the mortality. So maybe soon we will be embarking on this only.
The patient will be needing this anticoagulation.
Yes, a
for-
patient will be
for
requiring
lifelong.
anticoagulation. not for lifestyle, that will depend on CHAD-VAS scores. But yes, after ablation, patient will be requiring anticoagulation irrespective of the CHAD-VAS score for at least 2 months. And after that, we have to de-evaluate the CHAD-VAS score, and if CHAD-VAS score is high, patient will be requiring anti. Because as mentioned that there might be episodes of asymptomatic AF episodes are there. So basically, if you go for extended ELR kind of thing, then there are episodes of atrial fibrillation which are short lasting maybe, which are asymptomatic, but then this can lead to embolism and stroke. That we don't want.
If I want to talk for newer frontiers in AF management, can we mix this ablation with LA appendage device closure? Because even after this procedure, there is an incidence of stroke. So maybe near future.
But usually, I think
like
Dr. Amit will be able to answer this question. But LA appendage closure, we give a choice to those patients who are not able to tolerate anticoagulants, I think, if I'm not wrong.
Prefer to give LA appendage if the Has-Bled score is more than 3.
If the Has-Bled score. So
It's
patients
more than-
we are not giving anticoagulants to those patients.
No, you will not be able to give anticoagulation to those patients.
So if a
those
Has-Bled
patients-
score is less and CHAD-VAS score is high, suppose, then also you would like to go for LA appendage closure?
No, not really. Not really.
So only when
Because
Has-Bled score is
let
high.
me be very frank with you. LA appendage closure, most of the trials, if you see, you'll come to know that they still have a risk of stroke after 2 years.
Of stroke after 2 years.
Some risk will always be there. So if the Has-Bled score is more than 3, if the patient is a high risk for bleeding risk, any kind of bleeding risk, if you have to give triple antiplatelets or dual antiplatelets plus dabigatran or something warfarin, then these are the patients who are a good candidate for LA appendage closure, because these patients won't be able to tolerate those anticoagulation. The risk of bleeding is more. So we do LA appendage closure.
But the new guidelines, this ESC guidelines, they recommend even the Has-Bled score is more 3. What we say? One has to give the anticoagulant. Anticoagulant has to be stopped only if there is an absolute contraindication. Has-Bled score is the significance of Has-Bled score is that if it is high, then you should follow these patients very regularly. But it's not an indication that you should not give anticoagulation unless there is an absolute contraindication. Just like we have got an absolute contraindication for a thrombolytic therapy. It's just like this. One has to give it anticoagulant in spite whether he's has blood.
So the
score is 2,
guideline
3,
says
or
intolerant to anticoagulant therapy. Intolerant to anticoagulant therapy. That's the only indication for LA.
Probably a patient who is intolerant to anticoagulant and who has episodes of AF, sir, we can go for PV isolation and LA appendage
Yes.
closure.
Actually, there was a patient, you remember, she ended up having a pacemaker, but she had all 3 issues: tachybrady, paroxysmal symptomatic episodes on amiodarone. She bled on dabigatran first. She bled on rivaroxaban, then she bled on apixaban. But then she had more bradycardia. She had to go for pacemaker. She neither had a pulmonary vein isolation, neither LA appendage closure. Now she is on apixaban 2.5 milligrams, and for last 6 months she hasn't bled through her GI. So maybe if she bleeds now, she will be a candidate for LA appendage occlusion.
The last LA appendage, sir, we did in EHCC. This lady actually had paroxysmal AF, was on NOAX, bled on NOAX. Then we did the LA appendage. Now she's in sinus rhythm, not on any anticoagulant, not on anything. Not, I have even stopped her ecosprin because she was not tolerating that also.
So appendage occluder control the rhythm.
but even the LA appendage is not an
Maybe LA
Patient will
appendage
not-
was the trigger in that case.
stroke.
Dr. Kush, there is any role of pill in the pocket as of today, or it is just an obsolete like thing for paroxysmal
if
AF
you
or whatever?
Talk, I think practically speaking, sir, when a patient comes to me, young patient who has episode of paroxysmal AF, and it's very difficult to convince the patient to take a medicine for lifelong. Very, very difficult. All these medications are toxic. Be it flecainide, amiodarone, whatever, propafenone. Very difficult to convince the patient that you have to take a medicine. The patient compliance will not be there. He will not be ready for, even if he is not ready for catheter ablation. Suppose he is not ready for catheter ablation, and we are not able to, his CHADVAS score is less. So basically, we don't need to give him, any kind of NOACs. And his compliance is very poor with long-term antiarrhythmic medication. Then probably we can give him at least a pill in the pocket whenever patient has episode of atrial fibrillation. He can take all these medications. But still, when he has episode of atrial fibrillation and he takes pill in the pocket, so this will be he will be a candidate of pharmacological cardioversion. If you are giving flecainide to the patient, he will be a candidate for pharmacological cardioversion. Then you have to give him again NOACs for at least a period of 4 to 6 weeks. So pill in the pocket, whether it is
Yeah, it is. This concept is still very much alive, pill in the pocket, and it is more useful for those patients who are already on NOACs, already on antiarrhythmic therapy, but still they are having infrequent episodes. Then at 50 milligram of flecainide or 75 milligram of propafenone, definitely with beta blocker or calcium channel blocker. One tablet of verapamil or one tablet of metoprolol, and with some anti-anxiety, they can be used very well in pill in pocket.
But for paroxysmal AF patients, so suppose young patient with PAF.
Yeah, but then again, it is there, as you told, this is like a kind of concept of pharmacological cardioversion, so it may not be, maybe a tricky thing. But those who are already on established therapy, still having breakthrough episodes, they're exactly called breakthrough episodes, pill in pocket is still advised.
Got wrong. Suppose patient is not willing for ablation, something like that.
We all know that amidon is a very toxic
But
medication.
we don't have any alternative. What do you feel?
Then I think you are more experienced than me, sir.
As for the pill in the pocket approach, it is usually taken for patients who have very infrequent episodes of AF. It is not for paroxysmal AF, as you said. I mean,
Yeah,
it is kind of, it is happening once in blue moon or once in, like, in a year. Pill in the pocket is a very good approach for those patients. They can just keep it with them. And yes, they're paroxysmal, but I mean, not very frequent.
Yeah, not definitely for
Yes.
frequent episodes.
So
Patient
pill
has
in
to
the
take
pocket
medication.
is definitely there. It's not gone anywhere. It's still there and should be used in patients who have very infrequent episodes. As far as regular medications is concerned, my boss used to say in Canada that if you use amiodarone at 100 milligrams per day and it is controlling, I mean the lowest possible dose of amiodarone, let's say you are able to come to 100 milligrams per day, you can use it for lifelong. It's not going to affect the patient to a very great extent. It is only when you are giving it at 200, 400 milligrams per day that it becomes such a toxic drug. So it's a misconception that amiodarone is a very toxic drug if it can be brought down to the minimum basic dose, which is preventing for atrial fibrillation. You don't need very high dose. It is for VT where you need very high doses. So atrial fibrillation, if you, I have many patients who are going on 100 milligrams alternate day and they are not having atrial fibrillation right now, and they are continuing it for last 10 years, and I have not seen any problem of any kind of toxicities from amiodarone. So I think that is one point which needs to be told to everybody, that lowest possible dose, if it is less than 100 milligrams per day of amiodarone, it does not cause anything to you.
I think the thyroid toxicity and pulmonary toxicity, they are not dose related. The liver toxicity and other are dose related. So thyroid abnormality, because it is very well tolerated with thyroxine. So, but thyroid abnormality is not dose related. That can happen. Lung toxicity is hypersensitivity, that can happen.
Thank you, sir. Thank you so much.
So we come to the case presentation now. So I'll invite Chitresh to present the case which we did. So we have done just now only one case of cryoablation. So it is my request to the audience present here that you should help us in our program. So Dr. D.K. Garg, is he there? Dr. Sanjeev, Dr. Dhruv, has he arrived? आओ सर आओ. Dr. Amit Gupta. Dr. Nitin, please. And Dr. Dinesh, at least electrophysiologist should be on the dais all the time. Dinesh, please come. Dr. Sanjeev Roy is there. So maybe we can combine a quick panel discussion after this with this only. So I'll invite Dr. Gokhru sir also here, and maybe Milind, you can join us here. And our HOD of CTVS, Dr. Saurabh Jaiswal is here. So Saurabh, can you join us on the dais? So I think we'll take this case and then panel discussion very quickly because drinks are waiting for us. So Chitresh, you ready?
Thank you, sir, for the opportunity. So I'll be presenting. I feel fortunate enough to present our first ever case. I've been the part of the team. So this was a 43-year-old female obese female with a BMI of 31.7. She was very much aware of her symptoms from May 2021 of those symptoms being intermittent palpitations, irregular heartbeat, which interfered with her normal daily activities like walking and sleeping, and they had become very frequent with time. So this lady, she was having very unhealthy attachment with a pulse oximeter and used to check regularly. And she had, as sir said, a regular bigeminy arising from pulmonary vein, and the pulse oximeter would read a heart rate of 40, and that would fuel the anxiety. So she was very much aware, very medically aware, using pulse oximetry regularly. She has been prescribed multiple antiarrhythmics previously. However, there was no abatement in the symptoms. Her echo exam was normal. So, so we planned for her, after discussing with the patient, we planned for the cryoablation therapy. Prior to this, as the CHADS score was 1 only because of being female gender, she was not on any anticoagulation. When she presented to us, she was on flecainide and beta blocker. So we did a TE exam which did not show any thrombus or even sac in the LA appendage. Regarding the planning, before the planning part, we asked the patient to undergo CT contrast test. I apologize for the last minute, the MIP scramblings, especially to the radiologists sitting in the audience. So these are last minute scramblings, MIP renderings. So this is the AP view, and so CT is basically done to get a hold of the anatomical part. So how is the anatomy, whether there is a common joining of any two veins. So basically this patient had separate openings of all the 4 pulmonary veins. The diameters of the ostium were good, greater than 15 mm. So we can choose the balloon according to that, the cryo balloon. For more than 15 mm ostium, we require 28 mm of cryo balloon. And as we can see that the left inferior pulmonary vein had a very acute relationship to the LA floor. And so we anticipated some problem with LIPV in addition to the RIPV is very tough to tackle with cryo balloon because of being quite near to the fossa ovalis, the site of the puncture. So this is the right lateral view with anterior on this side and the posterior being this. And we can see this is basically this is a little bit of tilted view. This is the RIPV, this is the RSPV, and this part is the subclavian vein, superior vena cava. So this yellow dots is actually the course of the phrenic nerve which transverses on the anterolateral part and anterior to the RSPV. So this is the axial view. In this we can see so the RSPV, LIPV, and all the 4 veins. So what I want you to notice in this figure is that the esophagus is quite near to the LIPV and so is at risk to being damaged while cryoablating or even RF ablating this LIPV. So basically, because the right inferior pulmonary vein is quite hard to tackle, so it is recommended, it is considered to be a good practice for the patient to undergo transseptal puncture under some sort of guidance, either eyes or transesophageal echocardiogram. So for the planning part, we decided the patient to be having general anesthesia while undergoing the procedure. We took 3 femoral axes. Right one we took for the transeptal puncture. Left 2 punctures for access to pace the phrenic nerve, and second access to cannulate the coronary sinus. So we performed the transeptal puncture under the TE guidance. So this is the bicaval view. This is the superior vena cava and the inferior vena cava. So in this view, we decide how much superior or inferior we are regarding to the interatrial septum. The second view is the short axis view. In this, we look towards the puncturing the interatrial septum towards the aortic side, which obviously cannot be done only basing on the fluoroscopic views. So we took the Mullins catheter, and we punctured as you can see in this view. So we punctured at the quite anterior, quite close to the aorta. So this is the basic setup. So after having punctured with the Mullins, we exchanged it with the FlexCath advanced teeth, which is 14.5 mm. Prior to this, we actually dilated the femoral part, and we exchanged the Mullins over a J-tip stiff exchange length wire, which was parked in the left superior pulmonary vein. So in this view, you can see that we have exchanged the sheath. So currently residing in the figure is the FlexCath advanced teeth. The other 2 catheters you can see is, one is the coronary sinus catheter, and the second one is to pace the phrenic nerve, which is at risk of getting damaged while ablating the right-sided vein, especially the RSPV. So this is the basic arrangement which Dr. Kush has already touched upon. So basically, this is the tip of the cryo balloon. So the temperature which it monitors comes from a thermocouple, which is towards the proximal part of the catheter. So basically, what we are seeing, the temperature recorded in our consoles is the temperature of the formed nitrous oxide, which is returning back to the console. So it is, I need to stress upon this, that it is not the temperature of the tissue to which the catheter is contacting. It is the temperature of the rewarmed nitrous oxide which is returning back to the catheter, to the console. So after getting access to the left atrium, we anticoagulated the patient. The ACT, we required it to be close to 350. First of all, we proceeded with the LSPV because of being direct, having a direct approach to the vein. So we cannulated the left superior pulmonary vein with the Achieve spiral mapping catheter, which passes through the cryoballoon central lumen and through the FlexCath teeth. So in this view, you can see that we have cannulated the left superior pulmonary vein, and the cryoballoon, we have inflated the cryoballoon. So when we inflate the cryoballoon prior to freezing, it inflates at a pressure of 2 to 4 atmosphere, and the diameter, the 28 balloon which we chose, the diameter it achieves is 26.5 mm. So after getting a good feel of occlusion of the left superior pulmonary vein, we activated the freeze part. We pushed the balloon towards the antrum of the vein with the FlexCath sheath, and we simultaneously pulled the Achieve catheter to the proximal part of the vein so as to record the pulmonary vein isolation. However, our patient till this time was in atrial fibrillation, so we could not record those pulmonary venous potentials. So after getting a good feel that the vein is getting occluded, we started the freeze part. So this is the reading on our console. So this is the Arctic Front Advanced Pro 28 mm balloon. So after starting the freeze part, the time it takes to achieve minus 40 degree centigrade is quite fast, so which is a good thing. The nadir temperature it achieves is close to 50, which is also considered a favorable character for long-term resolution of AF. And finally, the time taken to thaw, that is to rewarm, it was also quite large. So it also gives us the benefit of that, yes, instead of not able to visualize the pulmonary venous potential, that the contact was good and the lesion provided has been very well. So at the 20 degree centigrade, the balloon deflates. at which point of time we stretch it with the push button on the catheter and we take it into the sheath again. So after having created a lesion in the left superior pulmonary vein, the patient fortunately terminated her AF and went into the sinus rhythm, as you can see in the later half of the figure. So then we proceeded to the left inferior pulmonary vein, so which, as we saw on CT, was quite having an acute angle to the LA floor. So as you can see in this figure, we were having quite trouble occluding this left inferior pulmonary vein with the balloon. So we tried a few maneuvers. So this was a hockey stick maneuvering in which you cannulate the inferior branch of the left inferior pulmonary vein and you push the balloon with the help of flex catch teeth and then try to occlude the antrum. So in this view, you can see that we partially succeeded and we started the freeze at this point of time. So this is the hockey stick maneuver. Next, while after having activated the freeze part, we pulled the whole assembly. So this is called the pull down maneuver, in which we are taking part of the inferior margin of the left inferior pulmonary vein. So by this techniques, we ensured that both the superior part and the inferior part of the pulmonary vein were covered. So actually, we provided a bonus freeze in this vein. And this was the maneuver of pulling down. So when you activate the freeze, that part of the balloon actually quite sticks to the superior part of the pulmonary vein, and when you pull down, it keeps its attachment to that part and also gets attached to the lower part. So that is a good thing of the cryo balloon, that when you activate the freeze part, it actually sticks to the part to which it is in contact with and remains stable. So then after having done the left inferior pulmonary vein, we proceeded to the right superior pulmonary vein, and the seal, and as you can see in this figure, this is called the ice formation, the ice crystallization, which has held the dye with it. So it is a very good sign confirming us that the occlusion has been great and the pulmonary venous flow has been occluded. So these are the pulmonary venous potentials you can see prior to activating the freeze, which we can see in our Achieve catheter. And after activating the freeze and after getting a good lesion formation, you can see that the pulmonary venous potentials have vanished. And these are the far field atrial potentials which you can see in the figure. So the time taken to achieve this was lesser than a minute, and which is again a good sign. And it is actually one of the primary endpoint on when to stop the therapy. The therapy has been by default set at 3 minutes, that is 180 seconds. However, if you can achieve the time to pulmonary venous isolation of less than 60 seconds, you can terminate your cryoablation at 2 minutes. So lastly, we proceeded towards the inferior vein, the right inferior pulmonary vein. Although it is mentioned in the literature that it is the most difficult vein to cannulate, because we took our puncture under TE guidance. So, and along with Dr. Makkar's expertise, we quite fortunately completed this vein in no time. So during the left-sided pulmonary venous occlusion or getting the lesion done, we monitor for the temperature through our probe, which has been inserted over here. So actually, it is quite a contentious topic. Most of the guidelines, they recommend for the temperature probe to be there and to monitor it for the decrement in the temperature in the esophagus. The cutoff, currently the consensus says is 20. If the temperature achieved on this temperature probe is less than 20 degrees centigrade, you stop the procedure at that point of time. However, in our procedure, we did not went below 32 degrees centigrade. So second part is that during the right side pulmonary vein, especially the right superior pulmonary vein, you have to monitor for the CMAP, for the pulmonary, for the phrenic nerve injury. So we are, as you can see, we are pacing the phrenic nerve from this arrangement, which consists of a ECG electrode placed at 5 cm above the xiphoid process, and another one being placed at 16 cm along the costal margin towards the right side. We are pacing, this is the phrenic nerve potential, and these are the CMAP. So these are the compound motor action potentials, and you have to monitor them for any reduction. The cutoff currently mentioned in the literature is 30%. Suppose the amplitude reduces by 30%, you have to stop the procedure there and then only. And you have not to rely only on your palpatory or during the fluoroscopy visualizing the diaphragmatic contraction. This is actually considered quite a sensitive measure for that. So these are the CMAPs and these are the QRS in between. So we completed our case in about 2 hours and 20 minutes with a fluoroscopy time of 36 minutes. And fortunately, we did not have any complication. The patient was discharged a day later on anticoagulation as well as antiarrhythmic.
Nice. So I'll just summarize the case first. I'll introduce Chitresh. He is our consultant cardiologist and our third pulmonary vein, you can say, in atrium of electrophysiology, because the first pulmonary vein is getting older, so we need younger people to come ahead. So he is one of the budding electrophysiologists and is an asset to our cath lab. So why we chose this case? Because she was very young. How old? 43, and very, very symptomatic. Every night she will just sit up and look at her pulse and take clonidril and also Indiral and whatnot. And she was already on flecainide. Why we chose cryo? Because she was very much, all the family was very much concerned about the safety. They have read everything on Google. फट जाता है heart, stroke हो जाता है ये वो, and they have read about cryo also. So I told them about cryo ablation. So definitely this is a safer procedure. As Chitresh mentioned, that we have to mostly take care of esophageal temperature during left-sided ablation and phrenic nerve stimulation and looking at the phrenic nerve palsy during the right-sided ablation. And that there is very methodical practice we do when we take care of phrenic nerve. So if we take care of that, rest everything is, definitely the incidence of tamponade and stroke is much lesser than the radiofrequency ablation. So that's why. One thing was there that this patient not only had paroxysmal AF but very frequent APCs, as we were talking about, and we were not able to find out on surface ECG whether they are left atrial or right atrial. So we knew that maybe after pulmonary vein isolation we have to do little bit patchwork to handle these APCs. So now, in such cases when there are frequent APCs and you have done PV isolation, still APCs are there, we need to take care of that. So either you take care of radiofrequency catheter now, because this balloon will take care of only pulmonary vein, or there are cryo freeze catheters similar to RF ablation catheter available. So it was there in back of our mind that we'll have to do something about this patchwork. But fortunately, after ablation of left-sided pulmonary vein, the AF, and interesting thing was that patient was in atrial fibrillation while we took her. We did cardioversion 4 times. It was not responding to cardioversion and responded to ablation on table. And till the time of ablation, there was no APC. So we concluded, but next day some APCs were seen, but her AF was gone. Symptoms had gone, and she is still asymptomatic. And procedure you saw, it was like smooth, like butter for the first time. So we were very fortunate to have such a good team as Kush and Chitresh and other people around. So it was a very smooth and good experience as a first case, I would say. So I would like to have your questions and comments.
Cryoablation, I think you have been a pioneer in multiple things as far as electrophysiology is concerned in the state of Rajasthan. And starting cryoablation is also something which I would commend you for. I mean, this is something which will bring a lot of atrial fibrillation patients to therapy now, because most of the people never went for therapy primarily because of multiple chances of having complications. Second, recurrence rates, and they would have to come for a redo procedure. I think both the things would come down with the cryoablation. So it's a very welcome step for the state of Rajasthan that we have cryoablation now in Rajasthan. As far as the case is concerned, what would be your tips to all the cardiologists as to what should be the case presentation and how we should be actually going ahead and trying to convince the patient for an balloon ablation in an atrial fibrillation status?
Yeah, so I think unless the AF is symptomatic, you should not convince the patient, and patient is unlikely to be convinced. So first thing is symptomatic, having a symptomatic episodes of AF. That is the primary thing, and that's what we are targeting. The symptomatic patients, relatively young people, then we can assure them about cryoablation that this is safer technique. The time is less, the fluoro exposure to ourselves is less, and also to the patient is less, and the chances of complications are less, and chances of reconnection, recurrences are less. But yes, we should not give any false assurance to the patient about need of anticoagulation or totally getting rid of medical therapy, but it can definitely reduce the symptom burden from the patient. That's what we should present to the patient as a case. And if we can assure about the safety, I think people are more likely to be convinced. See, I myself was not very convinced about AF ablation because of the complications. We did very rarely, we do atrial flutter, VT, every damn thing, but AF was very uncommon, like maybe once in 6 months in our lab, and that too was associated with complications, so we have burnt our hand with radiofrequency ablation. That's not the case. Very high volume centers are doing it day and night and with very good results. That's my own experience was not very good. But I felt comfortable after the arrival of cryo that now yes, we can do more and more patients for rhythm control with help of ablation in rightly selected candidates. Mostly paroxysmal, yes, because persistent I will not take, because then if I take persistent, I have to take a backup with the cryo catheter or radiofrequency catheter. Then we have to do 3D mapping also. So it is a very extension of the procedure. So definitely we will start with the paroxysmal AF only and only paroxysmal AF. Maybe as our experience grows and then clinical studies comes, as guidelines come, we can increase the scope of our indication.
Congratulations, Dr. Makkar and team. And it was such a nice thing to know about cryo ablation and all. My one concern would be, what should I tell the patient that what would be the recurrence rate after this procedure?
Roughly you can say 20 to 30%. Because
That is
for,
too less.
for SVTs we say 95% and more. For flutters and fascicular idiopathic VTs we say 90%. And for this we can say 70 to 80% chances that you will get cured. 20-30%. One very practical thing of the guidelines, these patients, even if they are on flecainide before and after ablation, it will matter for them. Just like we do for VTs, we put an ICD because we don't take chance. But if we do radiofrequency ablation for VT, the same amiodarone starts working which it didn't work before, or same mexiletine starts working. So it is like that also, that we can assure that first thing is that you will remain free of atrial fibrillation. If you don't remain free of atrial fibrillation, we can do a repeat procedure. If you don't want a repeat procedure, we can try medicine. They are likely to do better in your case, because frequency, because one little reconnection of pulmonary vein can lead to AF, but frequency will depend on how much pulmonary veins are available to make a nuisance, obviously. So it works.
Don't mind my questions, and I'm just a cardiologist. So, do you think that atrial fibrillation, we should do all the pulmonary veins, or we can isolate a particular vein? Because as you said, phrenic nerve can the problem आ सकती है. The right inferior pulmonary vein is very difficult to cannulate. The left inferior vein may cause esophageal problems, might cause. So is it easy to identify from which pulmonary vein it is coming, and then we can isolate that and we can do that?
No.
That's not possible.
No, not at all. We have to target all four. I have seen big people, very skillful people leaving RIPV just because they could not approach, and it was frustrating for half an hour. Then they just left. But like Chitresh said, anterior and inferior kind of septal puncture will give you easy access. If you are not happy with your puncture, do it again. A
Do all
skilled
four.
person can do it on heparin also. That's not an issue. Do it again and do the complete thing. Particularly if we are using balloon, it is easier than radiofrequency ablation. If we are using balloon, you cannot do substrate modification. So at least 4 PV isolation is something we have to assure and give to the patient.
Actually, in our electrophysiology meetings, this particular issue has been taken up multiple times. If you have one pulmonary vein which has been responsible for, let's say, left superior pulmonary vein atrial tachycardia is going on and that is causing atrial fibrillation, should we just isolate left superior pulmonary vein? And the answer by most of the stalwarts is that you have to isolate all the 4 veins. You don't need to isolate just
like
one
in
vein.
our case also, after doing left superior pulmonary vein, AF disappeared. After doing left inferior, even APC disappeared. Then we could have stopped, but no. आज ये है कल वो होगी. So any pulmonary vein can make a nuisance. So once you are inside the LA, you have to isolate all 4.
Okay, another thing that Chiteshwar said was that this patient had a CHADS-VASc score of 0 or 1 and therefore she was off anticoagulation. So I would like to bring this to the, to this August meeting. Did you anticoagulate her prior to ablation for 6 weeks?
No, we didn't. We instead did a TE, transesophageal echo. So that is also there in the guidelines that either you have to, the guideline says that either you have to do it for 6 weeks, or if you are not able to do it for lesser period and then do a TE. Even you are not able to do it, use good anticoagulation during the procedure and do a transesophageal echo. But post ablation, yes, whatever is the CHADS score, she will be on anticoagulation for 3 months. She is on anticoagulation for 3 months.
So did you do a transeptal puncture on anticoagulation?
No. We did a TE, then we did a transeptal puncture, and then we started the anticoagulation. That's how we should do in all cases, unless we have to repeat the septal puncture.
While cannulating right inferior pulmonary vein, do you take the help of T or ice probe, or there are different maneuvers?
Once you are inside the LA to hook any pulmonary vein, you just need your fluoroscopic experience and your imagination. There is no need of any imaging technology for just cannulating the pulmonary vein. You cannot see pulmonary veins very well, pulmonary vein ostium very well even on ice. You don't.
Okay. So how patient is doing now?
She is doing fantastically well. हम उसका वीडियो नहीं है हमारे. She is so happy.
Is she on some drugs or without any drug? Except anticoagulation?
She is on beta blockers because she had some APCs, and then after what happens is after withdrawal of these anti-tachycardia drugs, patient develops sinus tachycardia. So this is my policy, to keep patient on beta blocker for some time and then slowly withdraw it.
Okay, so there are lots of side effects of Googleitis. I think in this patient, this particular play, Googleitis help you get the patient ready for cryo.
In catheter ablation, radiofrequency ablation, the patient is usually kept on amiodarone or some antiarrhythmic medication plus anticoagulation for 3 months. So you have not given any rhythm control medicine. You have just given beta blocker.
She was on flecainide earlier, and we haven't given flecainide, but mostly it is done like it is just offline indication. It is just a theory that the lesions which you give, they take time for maturity, and probably the complete isolation takes some time. So there are reconnections early, but then they are again sealed. So these kind of thing force the operators to keep on antiarrhythmic therapy for 3 months, and it is safe for us also. At least for 3 months, patient
I believe it is safe for us because.
But then we have to withdraw slowly these drugs. Otherwise, then it will be cheating for the patient.
Yeah, so it's safe for us to keep on antiarrhythmics because the patient would otherwise eat your head off.
Yes.
After other things, what would be the anatomical shortcomings in the patient where you want would like to do cryoablations, means about the anatomy of pulmonary veins or something like that. Not the puncture, not the patient not allowing you and nothing like that. Only the anatomy of the
No,
left atrium.
anatomy just we had to know because very commonly there is common ostium for two veins, more commonly for the left sided veins, that you have a common ostium and and the orientation is different, so you need to have a CT scan beforehand, because here we are not doing 3D mapping. When we are doing 3D mapping, we don't do CT. Even CT helps, and CT carto merge was very popular, and even CT can be merged with end-site velocity also. So these are very good technologies, but for cryoablation CT is must, because we are not doing 3D mapping, so we should know beforehand किस pulmonary vein का मुंह किस तरफ है और इकट्ठा कहाँ है. That's it. But no anatomy will hinder us to do PV isolation. Particularly balloon is very good actually. Balloon takes care of more circumferential lesions, and if you can assure a good occlusion, and a 28 millimeter balloon will occlude any pulmonary vein size, and if it is a common ostium, we have to do twice or thrice for the same common ostium by pulling it, pushing it, or by giving superior orientation, inferior orientation, by making hockey stick or reverse. We have to do like this and look at the potentials wherever you can see.
These deflectable sheets help in cannulating the veins.
Yes, deflectable sheath only will help. Otherwise, it is very difficult for balloons to get into the pulmonary vein without a deflectable sheath.
So we use these sheets in this patient.
Yeah, this sheath what they provide is deflectable sheath.
This was only deflectable.
So this is a dedicated sheath for this.
How many times you can inflate this balloon?
We can inflate any number of times, sir. But इन्होंने वो लॉक लगा रखा है, 12 घंटे बाद नहीं कर सकते. 12 घंटे या 18 घंटे? 18 hours. 12 hours. So, but within 12 hours, whatever time you want to inflate.
So the compliance of the balloon is very good.
Yes. And there is no incidence of balloon rupture anywhere, nothing.
Sir, congratulations to your team and to you. Actually, seeing a new procedure and with this perfection, it is really great to see, definitely. It was a case in which LA was completely normal. So,
Yes.
is it possible in structurally abnormal left atrium to do this procedure, or we should defer those patients for doing this patient?
If you ask me feasibility, yes, it is feasible, because atria will dilate, pulmonary vein ostium will not dilate that much, and this balloon can take care of the pulmonary vein ostium. But the thing is, more dilated is LA, less likely that only pulmonary vein isolation will work, because then you need substrate modification also. Then you have to do some kind of hybrid procedure where you use cryo balloon for pulmonary vein isolation and other cryo catheter or RF catheters for other lesions, and making a substrate modification. So I would not like to do in a very abnormal LA, but like high normal 40-45 millimeter up to that we can do. And more like clinical thing, paroxysmal AF, yes, I would like to do even with dilated LA, but with high chances of recurrence, definitely.
Yeah, I think we had a very
I
nice
think the
discussion.
last panel discussion was left, but I think whatever was needed in panel discussion, we had a thorough discussion, because we were about to talk about anticoagulation and paroxysmal persistent, everything has been covered. So I think we won't take much of the audience time. So Milind, you can conclude.
Concluding that, I think we had a very nice discussion. So now it's time that we should disperse and enjoy the dinner. So thank you.
Okay, so maybe I'll take this privilege to invite all of you for dinner and cocktails. Thank you so much for your patient listening. Appreciate.
Hello.